evaluate our speaker just for future meetings and everything as well. If you could just a few housekeeping things. Number one, if you could just everyone turn off your electronic devices, cell phones, put them on vibe or shut them off. That'll help us out quite a bit. And then the evaluation forms I've handed out once again are quite important, so if you could fill them out before you leave, and we'll collect them at the back table there at the end on the way out. Our speaker for this session is Dr. Richard Goodfellow. He graduated from the University of Toronto Dental School in 1978. In 2000, his focus shifted to general dentistry, to TMD, sleep apnea, and orthodontics. He's on the board of directors of the AACP and is the current membership chair of the AACP International and responsible for the fundamentals course. Dr. Goodfellow practices at the TMJ Sleep Therapy Center in Toronto. So, should be a treat. Looking forward to it. And if you have any questions, we'll try to hold them towards the end, and we're just trying to get through it today. So, if you have any questions, let us know. Otherwise, welcome to people. Okay.
20 years ago, Teresa was a 35-year-old mother of two. She'd already been in my practice for 10, 12 years. And on one of her recall appointments, she turns to me and says, Dr. G, they call me Dr. G, can you fix my teeth? I don't like my smile. I don't like the way they look. I don't like the way they feel. I said, okay. Teresa was a severe crowded class 2, dip 2, hugely deep over by missing a couple of teeth, a whole bunch of unattractive teeth. So I worked out a treatment plan and spent 2 years fixing her. Orthodontics, fillings, crowns, and as we were finished at the end of 2 years, she gets up. She says, I am fabulously happy with my smile. But I got to tell you something. I go, what's that? I've known this woman now for about 12, 13 years. She says, for the last year, my migraines and headaches are gone. And I'm sleeping much better. And so I'm looking at her. I said, I've known you for 12 years. I didn't know you had these problems. She said, that's because you never asked. So, the point of today, I have to stand here. The point of all of this is I'm all about the literature. I have to help people through exams, help people become more certified, so I have to be very familiar with all the literature. I'm actually blessed to belong to an international study group, and we share 7, 8, 9 times a day literature about all sorts of topics that have to do with what we're going to talk about today. The key points of what we're going to do in the next 49 minutes is I want you to be convinced that obstructive sleep apnea is very common and very serious. I will prove that to you. That there is a very strong relationship between TMD and OSA, and that we, the general dentist, are, and our team, the #1 health practitioner by far to recognize this and deal with it. And I want you to not make the mistake I made 20 years ago. Ask the questions. Keep asking the questions. So where do we start? Well, sleep. There's a shape to sleep, an architecture. There's level 1 sleep, about 5% of the evening, 5% of the night. Good night, honey, your head hits the pillow, you're dozing off. If the dog next door started to bark, you may or may not hear him. Then there's level 2 sleep, which is about half of the entire night. Now that doesn't mean that your head drops down and you spend 50% of the whole night in level 2. There's a cycle. There's about 4 or 5 cycles through the entire night. But this is often called gateway. So you can move up, you can move down into deeper sleep. This is deep sleep, about 20% of the night. If we adults don't get level 3 sleep, we don't heal. If children don't get level 3 sleep, they don't grow. Remember that for the next 48 minutes. This is where hormones are produced. Level 3 sleep is where hormones are produced. Then there's REM. You've all heard about REM. It's about 25% of the night. It's where you get the memory consolidation. It's when our brain is healing, if you will. You get our moods and our emotions all starting to come together, and it's where you get the memory consolidation. This is what sleep should look like. Okay, yes, besides being very angelic, please look at one thing. She is breathing through her nose. She is breathing through her nose. We're going to pay attention to that over and over again. Please pay attention to this. Pay attention to the brain and the eyes. Something's happening here. Now, his eyes open. He actually woke up. That doesn't always happen. But when you have obstructive sleep apnea, your autonomic nervous system is not happy. Your autonomic nervous system is here to keep you alive. It will bring you up from deeper sleep to lighter sleep, sometimes waking you up, sometimes almost waking you up. And this is the point I tried to make in the structure of sleep. This gentleman is not breathing through his nose, he's choking, and he's having fragmented sleep, and he's kept alive by his autonomic nervous system. We're going to come back to that. What I want you to pay attention to here is not only was he choking at the veal pharynx and oropharynx, but I want you to pay attention that the nose and the terminates are very important. We don't pay enough attention to that. And that's going to be more evident in a little while. So, oh, Dad just snores, that's no big deal. Well, yeah, it is a big deal because it's been shown that just snoring can cause carotid artery atherosclerosis. Okay, and that is a very big deal. How common is obstructive sleep apnea? Well, again, I'm a general dentist, and I've been reading for the last 12 years, 9% of men, 4% of women have obstructive sleep apnea. I don't believe that for a second. I haven't believed that for the last 10 years because there's nothing special in my GP as far as the section of the population. And I'm telling you, in my experience, it's more than double that. And at least 50% of the individuals that come into my practice snore. And that's all ages. We're going to talk about that very soon. Straight up, Monday morning, if you have someone that you're taking a medical history on, they have drug-resistant hypertension, they have an 80% chance of having obstructive sleep apnea. Flat out from the literature. If they have congestive heart failure, 80%. And here, type 2 diabetes. This is growing, growing, and growing. Type 2 diabetes, you have a 72% chance of having obstructive sleep apnea. So, ask the questions. I'm going to give you tools later on in this talk that you can have to help you in your general practice recognize what's going on. Take 10,000 females, actually take 10,000 Swedish females. I know this is a beginning of a bad joke, okay, but there's a new study, and they took 10,000 Swedish females, took 400 out of the 10,000, and did a sleep study. 50% of this group had some sort of obstructive sleep apnea. That was a really big item, 2012. So, somewhere closer to the numbers I was suspecting is maybe what is reality. And what's the problem with having obstructive sleep apnea? Well, all of the above. All of the above, you have an increased risk chance of having any of these conditions. You're taking blood pressure, you talk about heart failure, arrhythmias, atherosclerosis, pulmonary hypertension, insulin resistance. When you see that gentleman choking, you see his brain activating. It's a sympathetic activation in the autonomic nervous system, simply meaning the body's in trouble. What happens is there's oxidative stress. What happens is the body becomes insulin resistant. When the body becomes insulin resistant, we're prone to type 2 diabetes. When we're prone to type 2 diabetes, we're prone to gain weight and not exercise. When we're prone to gain weight and not exercise, we're prone to obstructive sleep apnea. See how this goes round and round and round. This is a huge epidemic, I don't know how to pronounce that, epidemic. You get oxidative stress, you get endothelial oxidation. You get endothelial misfunction. You have cardiac problems. You have cardiac problems, you have more sympathetic stress. You have more sympathetic stress, you have more high blood pressure. We keep going round and round. Oops, sorry. Then we come to these. You as general dentists are going to see people on certain medications. They have SSRIs, they have benzodiazepine, they could have them because they have sleep problems and don't know it. They could be on those medications because they have pain problems and don't know it. Those drugs interrupt sleep. Those drugs screw up the structure of sleep. If you interrupt, if you fragment that sleep, you're prone to all of these problems. This is a big deal for the general society because the laboring on the, particularly in my province, Ontario, the laboring on the health system is huge. So, who are we talking about? Okay. I don't see these gentlemen in my practice. Certainly not for their sleep apnea or their pain problems because, let's face it, they're way ahead of the curve when it comes to needing help. So I'm not part of the discussion of should they be sent for a sleep study because that's a given. It would be very rare for someone of these guys to walk in my practice who don't already have sleep tests, who don't already have a CPAP, who aren't already on 6 medications because they have cardiac problems, because they have blood pressure problems and type 2 diabetes. My population base looks like this, and so does yours. The female, 25 to 55, who gets headaches and migraines, and you don't know why yet. The female who's exhausted, and you don't know why yet. But with a BMI, that's quite in line. In 2015, I had 6 skinny females from 17 to 28 with degenerative joint disease. They were getting headaches, they were exhausted, and yeah, look at this. My anterior bite's opening up. What can we do? And they already had braces twice. And they end up in my office. I will share with you what I did. I will share with you how, well, in my time, how I did it, but how I explored to find out what was actually wrong. What I'd like you to understand is do not be afraid to ask the questions when people who look like this have the problems you're surprised to hear about. But you won't know that unless you ask the questions. Don't do what I did 20 years ago. These are the risk factors. Yes, if you're obese, you are more likely to have obstructive sleep apnea. If you have a large neck, if you snore, etc., etc., etc. And you see this every single day. Your hygienists see this. And again, I'm going to give you tools, 3 particular strong tools before the hour is over as to what you can use on Monday morning to give you a structure on how you can find these people. 2 years ago, I had 2 35-year-old men, skinny little guys whose avocation was to run marathons. Fit little guys. They were exhausted. One of them had migraines constantly, and the other one was just tired even though he could run a marathon in 3 hours and 42 minutes. Okay? I don't mind being proved wrong. I sent them for sleep studies. Sleep Lab's going, good fellow, what are you doing? I said, just go ahead. I'm wrong about 6 or 7% of the time, unfortunately. So that means that out of the 5 people a day I send for sleep labs, I send for sleep studies, 5% don't need to be there. I'm reading the signs. I've been doing this for a while. It's not that I'm such a genius, you're going to see, and you're going to be given the tools today to start to understand what's going on. They had a collapsibility issue when they were sleeping. They had perfect BMIs. They were fit young guys, but in the middle of the night, their throats collapsed. So, we're GPs. We see this stuff all day long. Heavy bone, heavily worn down teeth. I spoke to a group in Toronto 10 days ago. I got asked to do that several months before because I met this individual at an implant course. It was an implant course. I actually had to be there, and so I started talking about stuff that was going on, and it was 300 people in this room, and these very prominent oral surgeons are placing these very sophisticated implants, and one of these prominent surgeons gets up and says, you know, sometimes you got to look out for these guys. They'll grind through anything. I don't know why, but they'll grind through anything. They'll grind through this, they'll grind through that. I don't understand it. So I'm at the back of the room. I've got my hand up like a 10-year-old needing to go to the bathroom. He doesn't call on me. So because I was going to tell him what this is. This is sleep apnea. Okay, he's very good at restoring, at placing implants, but we need to ask the question, how did he get like this? How did you get like this? Ask the questions. This is not just grinding your teeth. How do you get like this? Okay, you're going to see this, coated tongue. This is snoring. How did it get like that? Long use. Now this, you're going to see this on Monday. If you see this on Monday, this scallop tongue, the literature says 72% chance that person has obstructive sleep apnea. Flat out. If that person has a scallop tongue and snores, 82% chance of having obstructive sleep apnea. I like your odds of being right if you send him for a sleep study. Then you start asking questions. How do you feel in the morning? How do you feel in the afternoon? Does anyone complain about you snore? And if it's a guy, you'll probably get completely negative answers. They lie. And sometimes they just don't know. So quite often I ask the bed partner, the wife. And they're the ones with the truth. Cracked, chipped teeth. Kissing tonsils. Yes. If you had the privilege of listening to my buddy over there, Edmund Liam, on Thursday about Pediatric OSA, that is a wonderful resource that you have here in BC. Edmund Liam at the back there, okay, is a fabulous resource for any of you. He knows everything that I know, plus, especially about pediatric OSA. So do look him up if you have any questions. You're here in BC. If you're in Ontario, I'm your guy. You have kissing tonsils, you have a swallowing problem. You have a breathing problem. You have a child who breathes through his mouth. I'm going to show you this later. You have bags under their eyes. You have forward head posture. You have a structural problem. All of the above, all of this creating a developing problem. And then you see this. And this is where I had my wife, who's fabulous and a lot smarter and obviously a lot nicer than I am, told me I have to play well with others, because when I was in the implant course and they started showing cases like this, I started to put my hand up and say, well, why aren't we asking how they got like this? Of course, no one in the room was interested, and I didn't make any friends that day. But you need to understand that when you look at this, how did we get like this? This is sleep apnea. This is someone trying to stay alive. This person and this person will break through anything. Porcelain, metal, implants, loosen implants, break implants. They don't want to die. You saw what he was doing. So, we're general dentists. What are we going to do? Well, I know. We'll make a night guard. Well, sometimes that's a good idea and sometimes that's a horrible idea. The literature shows that 40% of the time, you can actually make their AHI, their apneic-hypopneic index, 50% worse. You're taking up airway. You're giving them something more to clench on, if that's the problem. You need to know what you're doing to that person. You can't just stick something in somebody's mouth and not know what you're doing and not know what the cause and effect is. So here we have a CPAP. Notice the air is going through the nose. And here we have an appliance. Notice the air is going through the nose. That's what we want to do. You need to take courses in learning how to understand this. You're not going to learn this in 2 days. You are not going to learn how to do this in 2 days from anybody. You need to spend time traveling and researching this to find out how the patient got like this, then learn how to treat them. Here's some samples of appliances. It's divided into two. There's tongue-retaining devices. There's mandibular repositioning appliances. I get asked the question, which one do I use? I can't answer that because everybody's different. Everybody comes from a different place. Everybody has a different tongue problem, a different tonsil problem, a different nose problem, et cetera, et cetera. Do they have a TMJ problem? We're going to cover that. But these are the devices. The literature shows that there's very little difference in effect when you're in this category here, and it takes time to learn how to deal with this. There are two basic issues you need to understand. When you deal with sleep appliances, there are often, at least 50% of the time, some sort of bite changes. Sometimes the patient is very happy about the bite change. Sometimes the patient is not. You need to prepare the patient for this right from the beginning. And sometimes there's jaw pain. It is rare for a sleep appliance to cause a jaw problem. It is not rare for the patient to have some sort of jaw issue before they actually come into your office. We'll talk a little more of that soon. And either way, you need to predict this before it occurs. So, let's go to the other side. I came originally from a world of treating pain. I had my diplomate in craniofacial pain long before I started to deal with sleep. It took me a little longer to start to put all of it together. Here's a wonderful study. 2,600 OSA patients, 1,700 TMD patients, and if you have 2 or more signs of OSA, you have a 73% chance of having a TMD problem, straight up. 73% chance. Here's another study. In Johns Hopkins, 88% who had TMD also suffered from sleep disorder. The relationship is very strong. If you want to stay alive in the middle of the night when you're choking, you will often perform sleep bruxism. You will clench and grind your teeth. The 50 minutes I have today doesn't give me the complete time to explain that to you, but it's a movement disorder in your sleep to keep you alive. Well, Rich, you pain guys, you sleep guys, well, what has that got to do with us GPs? Well, I still am a GP, and I'm going to tell you, in the Journal of American Dental Association, October 2015, last fall, 1 in 6 patients had orofacial pain. 1 in 6 patients in your office has orofacial pain. They complain of TMJ and muscular problems as much as they complain of tooth problems. It's your problem. You're just not asking the questions. It's very much your problem. So, I grew up in a time where there was all sorts of debates, professionally, about what is centric relation, what is normal, where do we go, where do we put the condyles, where's the disc, and so on. Well, the latest definition 1987, is anterior and superior, but on the disc. Okay, please remember that. Anterior superior on the disc. Okay, I have a lot of patients who don't have discs anymore. What do I do then? I have patients where half their condyles are melted away, and they're 20. Well, what do I do then? What book do you want me to open? Okay, well that's because I don't pay attention to the books. I pay attention to the patient. I pay attention to the patient's neurology. I pay attention to the patient's reflexes and where the patient wants to breathe. Make the patient's autonomic nervous system happy, and you've got a really good start of being successful. They're not going to want to break your crown's implants. If you're doing orthodontics, they're going to want to move to where you want to be, not against where you want to be. It's a much better way to go. This is really important. The more you study this, the more this is true. The company of those seeking the truth is far more enjoyable than those who think they have it. Remember that. I'm not sure who said it. I think it was some sort of movie producer. I don't know. But the point is this, that you're going to come across a lot of people who think they know what they're talking about, and you need to keep going and asking the questions. So what's normal? Well, here you go. Here's a sample of what's normal. Okay, disc between the two bones, fleshy space and centric occlusion, no clicking, no popping, depending on what morphology you are, dolicephalic, mesocephalic, brachiocephalic, you're somewhere between 48 and 52 millimeters opening wide. This is not normal. This is disc displacement with reduction. Click, click. Okay, that is not normal. That doesn't mean I'm going to treat that patient. I had a patient in 2 weeks ago, sent to me from another doctor. Doc, my dentist sent me here because I clicked. I go, do you have any headaches? No. Range of motion is perfect. Fabulous. Do you sleep well? Great. Everything else was 100% normal. I said, have a nice day. You don't just treat noises. I'm not going to treat them. Now, if he needed 4, 5, 6 implants, or a dozen crowns, I'd have a different conversation with the dentist. Maybe we need to look at something. But just because someone's making noise doesn't mean you need to treat them. Now you've got disc displacement without reduction. The disc is constantly right here. Now you have a limited opening. Now you have a quiet joint. And I'm going to give you a little tool in a few minutes to help write this down. But if this patient's been in your practice for 15 years, and they used to open 48 millimeters, 48 millimeters, 48 millimeters, come in for a recall, how you doing? Opening 32 millimeters. Oh, something's wrong. You need to pay attention to that. And of course, now we've got degenerative joint disease, okay, and that's simply the wear and tear. Now, you don't need to be an old person with arthritis to have degenerative joint disease. No, you don't. Like I said, I had 6 young females, scarily young, scarily fit women who had degenerative joint disease. And it's because the healing capacity of the joints was overcome by the forces they were putting on the joints. The healing capacity of the joints was overcome by the amount of force that they were putting on the joints. You have to ask, what caused that? Well, they're clenching and grinding. Well, what's causing that? I had to go back to sleep problems. A 115-pound female. What are you talking about, good fellow? I said, do the sleep study. Sure enough, upper airway resistance syndrome. There's a problem. These girls don't breathe through their nose. They have trouble breathing. There's a collapsibility issue. They want to survive. And there seems to be a female hormone component to this. I'm not sure. There's a great book, Dental Clinics. There's a David Hatcher's a radiologist. There's a great section in that about how he explains this, sort of, in the fact that right now there may be a link with the female hormone, and at a certain age, not allowing this to heal. But this is not a sentence or a death sentence for the condyles. And I have proven this because 3 of those 6 girls, I've actually reversed the degenerative joint disease. There are a lot of people who said, you can't do that, you can't do that. I go, well, yes, I can. And you know what? It's not my opinion. It was the oral maxillofacial radiologist report. 12 months later, degenerative joint disease halted and reversed. Remove the source of the problem, the body heals. So, how do we get these problems? Yes, could be motor vehicle accidents, could be something like this. That's not common. It could be a growth and development issue, which I'm going to tell you is probably a breathing issue from very, very, very young. But more than likely, especially the group that I see, it's clenching and grinding. Now, there's clenching and grinding during the day, and there's clenching and grinding during the night. If you're clenching and grinding during 4 o'clock in the afternoon, well, that's different than clenching and grinding at 4 o'clock in the morning. If you're pissed, if you have a job you don't like, if you're in traffic, I'm sorry, we can protect those people. We can't get you to stop grinding. I have a psychologist as part of my team because he's trained in sleep pain psychology for people. Basically, it's a cognitive behavior problem. So if you're hurting yourself at 4 o'clock in the afternoon, you need to speak to someone about that. I can protect you, I can't stop you. If you're clenching and grinding at 3 o'clock in the morning, well, now we understand the autonomic nervous system. I understand your wish to not die. I understand what's going on. I can actually not only protect you, I can get you to stop doing that. This is microtrauma. This is a bunch of literature that says that sleep apnea leads to sleep bruxism. There's a name you need to understand, Gilles Levine. Gilles Levine is the Dean of Montreal. There's pretty much nothing written about sleep bruxism without his name attached to it. He's fabulous. He's the Dean of Montreal, and he has a fabulous book that if you're thinking of getting involved with this, just Google his name and it will come up. One of his writing partners is a guy by the name of Dr. Barry Cecil, who was the Dean of University of Toronto, who is one of the world leaders in pain pathways. He has a fabulous book in orofacial pain. And the two of them got together and wrote a book. Guess what it's called? Sleep and Pain. And the two of them wrote this book, and it's amazing as far as all the literature and explaining to you the relationship between sleep and pain. You can't deal with one without the other, in my opinion, and apparently not in their opinion either. So there's a cause and effect. Be careful what you put in people's mouths. Be careful what you do. You need to monitor this. You need to make sure you're headed down the right road rather than the wrong road. So we have macro trauma and we have micro trauma. You need a diagnosis before you put something in somebody's mouth. Is it just the pain and sleep world? No, it's not. Let's look at what the guys who do some serious restorations, let's see what they have to say. Sleep bruxism and orofacial pain are conditions for which the dentist has diagnostic and management skills. Yes, that's true. Sometimes. Due to the complexity and extensive amount of time and money involved in rehabilitating mouths, prosthodontists should include a mandatory screening for OSA and their patients. So, back to the lecture when I was misbehaving at the back of the room. These guys never asked the question, but the position paper for prosthodontists says you need to ask that question. Before you put 12 crowns in somebody's mouth, before you spend all that money, you need to ask the questions. This is their position paper. Fabulous. Somebody's catching on. Now let's talk about the other half of the population. Kids can't have this problem. They're too cute. This is sleep apnea. This is sleep apnea. This is sleep apnea. You see this. You'll see this before lunch on Monday. All of you. all of you in the GP office will see some of this before lunch on Monday. You'll see these kind of bites. You'll see these kind of bites. This is a person who can't breathe through their nose, may even have a tongue thrust. And you know, I'm old enough to know that to experience that when some people that were doing orthodontics and a patient had a tongue thrust, they put this crib in the back of the upper side so the tongue would reflexively go back. Wow. Okay, so here's a person who's choking to death, and the tongue wants to get out from the back of the throat, and now we're going to stick 3 knives, and we're going to cause the tongue to go back down the throat. Fabulous. So, you know, this person ends up in the hospital, of course, because they can't sleep at all. They can't breathe at all. When you weigh this amount and you lie back, the pressure on the heart and lungs is way too great for you to breathe properly. This is sleep apnea. The bags under their eyes, the mouth breathing, the bags under the eyes, the sweating in the middle of the night, the misbehaving. You're exhausted, you can lie down. A child's exhausted, they misbehave. They don't pay attention in school. Here's again where I don't play well with others, okay? So I get a mother bringing a child in and the kid's on 2 kinds of medication. Ritalin, or something to that effect. Okay, because the child misbehaves. And I look down the throat and I see class 3, class 4 tonsils. I go, well, when did you talk to the doctor about a sleep study? And she goes, well, what are you talking about? So I said, let me understand this. I said, your 10-year-old child are on medications that if I took would put me in the hospital, okay, but nobody asked how your child spends a third of his life. And I get this with adults too. It gets me upset that we don't ask the questions that, especially in Ontario, you know, you come in with a migraine, here's your medication. You come in with a headache and you're exhausted, here's your medication. Well, why don't you ask how you spend a third of your life? Maybe something's wrong. Maybe you don't need the medication. And I also tell my patients that as I make them better, and I can do this usually 95% of the time according to my statistics, that quite often, now the medication, you're going to start to feel unwell again. Why? Because you don't need the medication. If I took those pills, I wouldn't get out of bed. And these people are walking around taking 3, 4, 5, 6 kinds of medications. I'm doctor number 6, 7, or 8, okay? And sometimes they've even had surgery. Sometimes they've had disc removal. How do you explain that to somebody who says, well, here's what's been happening, and you spend the time, we're going to talk about this in a few minutes, you spend the time explaining to them what's wrong with them, what their options are, and they look at you like, well, why am I on all these things? And I don't have an answer for that, except maybe they didn't ask the questions. You see some serious problems, ask, well, how are you spending a third of your life, i.e. sleeping? Here are the problems. Here are the signs. I have a handout for you if you email me. It's wonderful, we'll get into it in a second. But this is everything and everybody you're going to see by the end of Monday. All of these signs. If you have mouth breathing, you have, as an adult, you have forward head posture. You have forward head posture, you have shortening of the muscles. You have shortening of the muscles, you often have headaches. Ask your patient, when do you have a headache? The very next question, when do you have a headache? Is it in the morning or is it at night? You have a headache at 5 o'clock in the afternoon. That's a structural problem. It could be a tension problem. It could be a new eyeglass problem. You wake up with a headache. That's a sleep breathing problem. Well, I'm stressed, not this. Well, no, you're unconscious. Okay, you're unconscious. You wake up with a headache, that's supposed to be your best time of day. Your tank is supposed to be full at 7 o'clock in the morning. You're not supposed to wake up sick. You're supposed to wake up well. That's what 450,000 years of evolution has done for us. We're supposed to wake up better than when we went to sleep. That's our recuperative scenario, okay? You're not supposed to wake up sick. You have crooked teeth. You have a breathing problem. You have a child who breathes through his mouth. That's an orthodontic problem waiting to happen. So let's keep asking the question, how'd you get like this? Well, how'd the teeth get crooked? Well, it's a breathing problem. Well, why aren't you breathing through your nose? Well, because the kid can't breathe through their nose. Well, maybe the child never learned to breathe through their nose. Maybe the child ate stuff that caused inflammation that didn't let the child breathe through their nose. There's two women sitting in this room right now. One is lecturing right after me, who makes it a life work on teaching kids and adults how to breathe. Well, I know how to breathe. Well, no, maybe you don't, because maybe you've been eating Cheerios and Fruit Loops since the day you were born, and you don't know how to breathe because you've been breathing through your mouth since you were a kid. Maybe your tonsils are huge because you mouth breathe. Maybe because you eat foods that cause inflammation. Maybe you're not as well as you think you are. I had a mother last month. I'm doing my orthodontic. In fact, she's an MD. She brings her child in because he's got ADHD and crooked teeth. I'm doing my examination. I touch his TMJ capsules. He leaps out of the chair. The mother leaps out of the chair. She goes, I go, that hurt. He goes, yeah. She goes, that hurt. She goes, yeah. Don't yours? He's 10. He doesn't know any different. They've always hurt. He's always breathed through his mouth. He's always not slept. You can't ask him how he is. You have to ask the mother. Sometimes the father. So who's counting on you? Well, all of these people. This is who walks in your office. This is who walks in your office. This is who could need your services if you ask the right questions. Don't stop asking the questions. We'll get to that list in a minute. So all of these people, I thought when I first started in my pain world, okay, I thought I was just going to deal with this and deal with this, and that's all I was going to deal with. Oh boy, was I wrong when I started to find out what was actually causing all of this. It's often a breathing issue. So, you guys screen for cancer. You guys screen for periodontal disease. Nobody has to teach you that. Why aren't you screening for TMJ problems and obstructive sleep apnea problems? You saw the statistics. You saw what percent of who's going to walk into your office on Monday with muscle and TMJ problems, 1 in 6. You need to start screening for this. A word about CBCTs. They are a fabulous tool. And in my fabulous province, I, as a GP for 38 years, am not allowed to own a full screen CBCT. In every other province and every other state, yes, but not in Ontario. I guess Ontario dentists aren't as capable as everybody else on the planet, but that's the law. Okay, so I have the luxury of now sending them to an oral maxillofacial radiologist. The upside to that is I get a great report. Here's 2 o'clock in the afternoon, sitting upright, teeth together, 1.2 millimeter back of the throat airway. So, this is not diagnostic of obstructive sleep apnea. But here's the deal. At 2 o'clock in the morning, that doesn't get bigger. It only gets smaller. So it's a useful tool. This is right out of a textbook. If you email me, I can send you this. Here's the just a part of this. I want you and your staff to have this. There's a whole list of signs and what the relationship can actually mean as far as TMJ problems and sleep apnea problems. It's a wonderful guide. It came right from a book, Dental Clinics by Bailey, and I'm happy to send it to you. Here's another one, which the mother should fill out while the hygienist has the child in the chair. And it has all of these questions, and you can ask the mother, sometimes the father, you can ask the mother these questions, and they'll start to there's enough questions, and yeah, tossing and turning, yeah, the sheet's in above the floor, yeah, the kid's sweating, yeah, there's some snoring. Kids shouldn't snore. American Pediatric Association, any child who snores needs a complete sleep diagnostic workup. This is the one I made. You're welcome to this. It should be in all of your recall sheets. And what it does, it trails on and on for years, and your hygienist asks every single one of these questions. Headaches should have AM, PM, or yes, no, and if it's yes, it should have AM, PM for the reasons I just gave you. You need to ask all of these questions. If at 10, 12 years ago they were opening 48, 47 millimeters, no problem, and all of a sudden they come in and now they're opening 32 millimeters, something happened. So you need to start asking the questions. You need to monitor for all of these questions. Are you sleeping well? Yeah, I'm sleeping fine. Well, make sure you ask the wife too. Okay. So I was treating pain patients for a decade before I started to really move and connect into the sleep breathing as having a huge responsibility for what was going on. This is my consult room, and my staff knows that this must be sitting next to the chair in the consultation room. Because 8 to 1, women to men, sitting in my consultation room. If it's a child, of course, the mother should be there with it. But 8 to 1 is my typical day of a female sitting in the room telling me her story. I've done a complete workup. They've already been in my office for a full hour before I actually walk into the consultation room. My staff has got this amazing protocol, and by the time I come in, the story has been told, the corrections have been made, and she has a very good understanding of what's going on. I come in and I start to review this with both my staff and the patient. When you start to explain to a 35, 45, 55-year-old woman that they're not crazy about the screwdriver they feel is stuck in their head, when you explain to them that the extra 30 pounds that they can't lose is because they can't sleep at night and they don't have normal hormones, when you explain to them that their child is misbehaving because they have this fabulously horrific diet of sugar and they haven't slept because they can't breathe because the tonsils are the size of golf balls, when you explain to a woman that she's not crazy because she's taking 6 times of medication and she just doesn't feel well, get ready. Get ready because the tears come. And it's not a horrible thing that the tears come because you're going to see something in her eyes that she hasn't had for a very long time. It's called hope. And if you think fixing teeth is fun, if you think making things white and putting them straight and putting crowns with nice margins is fun, you're giving their lives back. That's a real kick. When they turn to you in 12 weeks and they can't leave the office without hugging and kissing you and turning to the staff and they have to come back every year for monitoring, and you see that you've maybe only taken 70% of the pain away, but they're off medication. They're back to exercising. They're back to being with their husband. They're back to working. They're back to a college student is back to studying again. The fog is lifted off of their head. You need to have this in the room. In summary, sleep-related breathing disorders are common. They're serious. Learn to recognize them. 80% today go undiagnosed. There's a very strong link between temporomandibular joint dysfunction and sleep-related breathing disorders. We are, as GPs, because of your recall system, because you see patients every 3, 4, 6 months, because you can train your staff to ask the questions, because you can train your staff to do all these things before you even get your butt to the recall room, you're the #1 team that can recognize this. Anyway, so what do you do now? Keep asking the questions. Never stop. Thanks a lot. Any questions? Wow. Okay. Oh, yeah.
I was wondering, I work in the muscular office and thinking about sleep tests. So I was wondering, are those enough probably?
The only person that can diagnose a sleep disorder problem is a sleep medical doctor. Period. A dentist should not diagnose a sleep problem. Only a medical sleep doctor. Anybody else? Yes?
So how would you get an ENT on board to rectify? Because a lot of ENTs still don't recognize a lot of this?
100%. Try, and try. Take CBCTs where the nose shows the nose get a radiologist report where you see that the nose is a problem, whether it's adult, show that to the ENT and say, listen, this person has all of these symptoms, look at the nose, what can you do? The child, okay, has a tonsil problem, look at the morphological changes. It says right here, you should be taking out their tonsils or dealing with if there's a morphological change. What can we do about that? That's not an easy job. Are you in BC?
I'm in Alberta.
You're in Alberta, okay, in Ontario it's even worse.
Yeah, they don't really recognize.
It's just horrible, but
Yeah.
but you just have to keep trying. I got really lucky because a sleep doctor ended up with a TMJ problem. Come on home. Now we understood what the heck I was talking about all this time. Yeah, I'm sorry, you just got to keep at it.
Okay.
I don't have any magic.
I want to add, one of my colleagues, for his child, he insisted the ENT scope the area, and that's when the ENT actually conceded, will actually do the surgery.
That's
Great.
Then,
So you're right, you just have to question.
and a screaming mother is fabulous. I tell the mothers, go nuts, go absolutely, it's my child, there's this, give them the whole list. A doctor will pay attention to a screaming mother. Something over here? Yeah, sorry, yeah. Yes. Yes. Let me share that. So the statement was a 10-year-old boy with rapid palatal expansion that the sleeping and the bedwetting got better. You can cure, pay attention, you can cure children of OSA. You cannot cure adults of OSA, you can manage them. Rapid palatal expansion with tonsil adenoidectomy, you can actually stop obstructive sleep apnea. So the treatment of choice, half the time it works with just tonsillectomy, tonsil adenoidectomy, and if you do both with rapid palatal expansion or just palatal expansion. I'm a big fan of not rapid palatal, slow palatal expansion, okay? That works fabulously to get the AHI down. I actually do sleep studies before and during my orthodontic cases. There was something over here, yes?
I see a lot of some children really young, where they're overwhelmed and the parents tell me that their children are drowning.
Right. Yes, that's an airway problem.
Noise,
That child can't breathe. That child belonged in that picture. You need to start at the beginning, look at the tonsils, look at the nose. Look at the nose. Look at the tonsils, look at the nose, start with the ENT. Don't put something in that child's mouth to protect the teeth. Okay, start.
Yeah, how about, like, I still ask the parents what they're doing with kids before they go to bed, make sure you're well rested.
Look at the diet. Absolutely. Look at inflammation. Absolutely. Look at inflammation. Talk about diet. Talk about the timing of eating. Talk about the sleep patterns. Talk about there's so much to deal with this before you start taking out and doing permanent changes. Absolutely. Can't cover that in 50 minutes.
All right, guys, thank you so much for this amazing presentation. Please do fill out your